Okay, so today we're going to talk about the safer guides. Um, and so we appreciate you sharing your time with us today. I know it's valuable. Um, if you're willing, we would love to see you on camera. If you don't want to be on camera for whatever various reasons, we obviously understand. You should be able to unmute yourself. And so if you do have any questions or something to share, go ahead and unmute. If we happen to hear background noise, we'll mute you so that it doesn't get into the recording and isn't distracting. You can also interact. Maria on my team is going to help me today. And then if you have any questions, please either unmute and ask during a slide transition or type it in chat and Maria can read it off to me. So I always put abbreviations into my slides, and some of them are kind of spelled out in the slides. Some of them are pretty common, so they're not. But there's the abbreviations so that there's a quick reference if you have any questions about what something means. Um, Today's session is actually two parts. We have kind of the background and the overview of the ASTP Safer Guides, which will be about 30 minutes. And then if you want to hang in and actually start diving into the High Priority Practices Safer Guide and go through like the questions and have, we can answer any questions, that kind of thing, that'll be the second half of the meeting. So our agenda today is a brief background of those ASTP Safer Guides, as well as a general overview of the Safer Guides, and then an overview of the high priority practices specifically. And then we'll do a Q&A. And then, like I said, if you all want to just hang around, we'll do a deep dive, and then we can do a Q&A on the deep dive. So as far as the SAFER guides, SAFER is Safety Assurance Factors for EHR Resilience. They were developed initially by the ONC, which is the Office of the National Coordinator for Health IT, and released in 2016. They were updated for 2025 and released by the Assistant Secretary for Technology Policy. And honestly, that part, I didn't realize it had kind of transitioned to ASTP until I was looking at the guide yesterday, and it didn't say ONC anymore. Um, they're based on the best available evidence from literature and consensus expert opinion. When they were updating those, subject matter experts in patient safety, informatics, quality improvement, risk management, human factors engineering, and usability all developed the guides that were reviewed by external groups of practicing clinicians, informaticians, sorry, that word was tough this morning, and information technology professionals. So they pulled together quite a stakeholder group. There's actually a section of the guides that show what the like who was involved in those, and it's usually several pages. Um, they were designed to help healthcare organizations conduct proactive self-assessments to evaluate the safety and effectiveness of their EHR implementations. And the goal is to improve overall safety of the healthcare system and improve patient outcomes. And so when they revamped them for 2025, they actually dropped it, I believe, from like 144 recommended practices to 88, and they added new things in. So, like, they really kind of redid the way that the assessments work. Um, there are 7 safer guides that cover various topics that have 88 unique recommended practices now. Those guides are categorized as foundational, infrastructure, and clinical processes, and they're available on the internet as a fillable PDF. And I just realized, hold on, I'm going to see if I can pause my share for a sec. Um, Actually, I'll get my website. Here we go. Wanted to make sure I had my website in the background. Because we'll actually take a peek at it here in a minute. The high priority practices that we're going through is actually a compilation of the other 7 safer guides. And so it took pieces from everything else and put it together. I believe there are 16 of them that are those kind of high priority practices. The other safer guides are organizational responsibilities, patient identification, clinician communication, test results reporting and follow-up, CPOE with decision support, systems management, and contingency planning. And so that systems management guide used to be two separate ones. It used to be system configuration and system interfaces. They actually combined them when they were amended in 2024. The updates were actually completed for the 2025 version of these documents in August of 2024. Each of the guides has a structure to it. And so there are general instructions, there's an introduction, table of contents. Those authors and peer reviewers are the folks that were involved in creating and reviewing that guide. There's also a checklist, team worksheet, worksheets for the recommended practices, and then references. And so the checklist itself actually lists all of the recommended practices on that particular SAFER guide. The team worksheet is where you note your assessment team leader, assessment team members, assessment team notes, and when that was completed. The team notes can kind of serve as a summary, conclusions type of field. And so that's where you can note things that maybe need to be done as far as as team members, if there's something that hasn't been implemented. It's somewhere where you can note if there are challenges, if you're having like open staffing positions or something like that, those can be noted. The worksheets themselves are like the bread and butter of this. And so all of you have done HIPAA risk assessments. And so the worksheets are kind of that. This is the requirement. What are you doing? What might you still need to be doing? And then the references are the evidence-based support for all of the for the recommended practices. So the worksheet elements, because like I said, that's kind of the bread and butter of the process. It lists the recommended practice, and then there's an implementation status, which is a drop-down list of 5 options. So anything on this slide that you see in italics is actually something that you would fill out as a clinic completing them. Sorry. The options in that drop-down list range from not implemented, which it considers 0%, to making progress, which is they indicate as 1 to 30%, halfway there, which they indicate as 31 to 60%, substantial progress that they categorize at 61 to 90%, and then fully implemented, they've placed it like 91 to 100%. So if you're almost there, there's just a few little things you can still note those as fully implemented, especially if there's something that you're already planning to do to sort of complete that implementation. There's also an EHR limitations checkbox, and that is new this year. And I know there is a hospital that I helped complete these because the hospitals that participate in the MIPS program, they have to complete all 7 of them. If you participate in MIPS and are required to complete these as part of your promoting interoperability, which as a general rule, health centers are not going to be required to do the MIPS piece as far as promoting interoperability. But if you're in like a Medicare shared savings program or some other sort of value-based care arrangement, they may want you to complete these in order to participate in the promoting interoperability piece. So certainly ask questions of whomever is facilitating your value-based care arrangement. But one of the things that I found when working with this hospital was, sometimes there's something that is considered a recommended practice, but that's not actually what the EHR has available for you as an option. And so then you can check that EHR limitations box, and you can make a note in the assessment notes of why there's a limitation. The rationale for the practice or risk assessment is also available, suggested sources of input, and so that's kind of the staffing roles that may be able to help identify what you're currently doing, and then what may need to be done. It also includes a strength of recommendation, which is either a medium, high, or required. Medium, strong, and required. And so that kind of tells you where they're prioritizing that particular recommended practice. There's also implementation guidance. And so the two pieces that can be really informative of what exactly and why do they have this as a recommended practice is that rationale and that implementation guidance, because the implementation guidance is kind of examples of ways that you could implement this practice. Um, it's not going to be something that you're going to have all of those things implemented. It's just sort of examples of how you could. The assessment notes, the follow-up actions, and the person responsible are all fillable text boxes. Um, so the assessment notes is where you're at, like what do you currently have in place? What does the EHR do? How is it configured? That kind of stuff. If your implementation is anything other than full, you also want to note that there is a follow-up action and who is going to be responsible for that, because that's what your organization is going to do to get to full implementation. Um, any the thing there are several things to keep in mind. CMS does, as I mentioned, require completion of the High Priority Practices Safer Guide for eligible clinicians participating in MIPS, promoting interoperability. Again, reach out to your MSSP facilitator if you think this may apply to you. Also, every organization is unique and may implement these recommended practices differently. And so not all of that implementation guidance is going to apply to you, and you may be doing something different that's not even listed in the implementation guidance. And that's okay. Just, the important thing is to be aware of what you do have in place, and how you're addressing these things. Also, many of those safer recommended practices require EHR vendors design and develop the software required to enable users to complete those recommended practices, but they also require effort on the part of clinicians and healthcare organizations to configure, implement, and use the EHR to its fullest extent. So that may be configuration, that may be training, that may be doing, those routine updates that come out. And so some of them are in, like, the systems piece definitely is sort of heavy on the IT vendor side, but there are still things that practices can do. There are also some limitations to the safer guides, and so they're not intended to be used for legal compliance purposes. Implementation of one of the recommended practices doesn't guarantee compliance with, like, HIPAA security or privacy rules, Medicare or Medicaid conditions of participation, or other laws or regulations. As we look at these, you will see that there is overlap, especially with HIPAA. But those laws all require, I know at least from a HIPAA perspective, it requires an assessment that you do the security risk assessment so that you know where you're at with your privacy and security compliance. And so those two pieces are related. The risk assessments are related to these safer guides. They both kind of work towards the same purpose. The safer guides are informational and not intended to be an exhaustive or definitive source. They do have a lot of information, though, because those references at the end do have a lot of resources. If you ever want to dig deeper into something, they give you a lot of places to start. And they do not constitute legal advice. And so, any questions so far on just like the safer guides as a whole? Okay. Um, so the high priority practices safer guide specifically, it's a foundational guide. It is 16 of the most important and relevant recommended practices selected from the other 7 guides. So like I said, the hospital that I worked with last year when we did these, they actually had to do 9 guides because there were 2 that got combined and they had to do these high priority practices. This year they do 7 because 2 are combined and this high priority practices is a combination. And so they just have to do the 7 because they've already answered all of the high priority practices questions in the specific guides. Um, they're designed for practicing clinicians to help them understand, implement, and support EHR safety and safe use within their organization. And so it's really about that awareness and that understanding, and when needed, that, what's the path forward to implement this kind of a thing. Um, the recommended practices are considered the most crucial for clinicians to help mitigate safety risks and gives them an opportunity to advocate for organization-wide prioritization of recommendations that have not yet been implemented. And so, especially as we look at this guide, if there's a recommended practice that is kind of low on the implementation scale of those sort of 5 things that you can pick from, um, and it is noted as like required, that would indicate to you that this is a high priority thing that they want to make sure that healthcare organizations are doing and can help prioritize some of those tasks. Patient safety risks, as we all know, can be both social, which is the people side of it, and technical, which can include hardware, software, the software configuration. And so there it addresses both sides of that. The goal is to prompt clinicians to ask questions and hopefully start conversations among other staff, clinicians, administrators, IT professionals, so that everyone can work collaboratively to design, develop, and implement safe and effective EHR systems. It also helps design a plan for the future. And so it helps to optimize EHR related safety and quality. Also, as I had mentioned before, to set priorities among the recommended practices that are either not yet addressed, or again, even if it's kind of low on the implementation scale, something to continue to work on. It helps ensure there is a plan in place to maintain those recommended practices that are already in place. And it allows organizations to dedicate the required resource to make necessary improvements, because we all know that in order to change, you definitely have to dedicate some human resources to it. Sometimes you have to dedicate some financial resources to it. And so, like, being able to prioritize those practices helps make decisions about kind of what should be next first. And also working together to mitigate the highest priority safety risks that are introduced by the EHR. In the High Priority Practices Safer Guide, there are 3 domains. Safe Health IT is the 1 dot something questions. Using Health IT safely is the 2 dot something questions. And monitoring safety is the 3 dot something questions. It covers topics that include organizational culture of safety, including staff training, because we all know that staff training is important, technical controls and configurations, data backup and testing, which again, you'll probably recognize as overlapping with HIPAA, both the backup and the staff training. It also includes things like artificial intelligence, reduction of burden, patient identification and care, and downtime operations. And so, like, it does cover a pretty broad, for only being 16 questions, it covers a pretty broad group of topics. So if you want to follow along, oops, hold on. Those were my links. I'm going to pop that link into the chat here real quick. And so these are, if you want to follow along, you can go out to the Health IT or the ASTP ONC website. If you're looking for information about the safer guides in general, I'm putting in a different link that just takes you to the page that has all of them, but the first link is going to take you to where we are going to talk next. And so, do you see the safer guide up on my screen now? Okay. The second website I sent was this one, and so it has both the 2025, which would be, if you choose to do this, the ones that you would want to complete. And again, the high priority practices is right there. It's the first one at the top. The 2016 Safer Guides were those original guides that had gotten released um, back in 2016. So, as I had mentioned, there's kind of the general instructions that kind of apply to the Safer Guide as a whole. If you happen to read through any of this, some of the stuff in my slides is going to look familiar because I pulled a lot of the information from the slides themselves out of either this general introduction piece or the introduction to the high priority practices specifically. And so for this self-assessment, whichever one that you're working on, in our case, the high priority practices, it also talks about that specific guide and how to use that information and, what it's intended to be and that kind of stuff. And so this is kind of the overview of the process. The table of contents does have links. And so if you click on one of these pages, it's actually going to take you to that specific worksheet or the team worksheet or wherever it is that you're going. Clicking those page numbers will link you there. I had mentioned, that the one dot something questions are the first domain. These two questions would be the second domain, and the three questions would be the third domain. And so this is where the people who participated in the process, whether they helped develop it, whether they provided feedback, there's a whole list of folks. Um, excuse me. This is kind of the instructions. And so, like, it tells you how the guides break down. And so the first piece is the checklist. Now, the nice thing about the checklist, if you're just kind of trying to get an idea of what kind of information am I going to need to gather, this is a great place to start. And so it has what each of those recommended practices are. And then in the original version of the documents, when you actually did the worksheets, whatever you put for implementation status actually carried through to here. It doesn't in this version. And so how I usually approach these is we actually go to the worksheets and complete it, and then I make notes and I come back to the checklist to note what our implementation statuses were. And so it shows you, like I said, what each of those are by their domain. And then it goes into your team checklist or your team worksheet. So this is where you put who is leading the effort, when was it completed, who are the members, and then those assessment notes. And so, like I said, those are the, as we move forward, keep in mind kind of things. And so like I said, they can serve as a summary, they can serve as a reminder of something that was a challenge, that kind of thing. So it's kind of those important key takeaway sort of things. And then this is the instructions for how the worksheets set up. And this is where you really start digging into the meat of the process. And so it tells you this is your recommended process. This is the rationale for that particular process. These are those suggested sources of input. And so some of them are broken into large organizations and small organizations, which I think is helpful. I would imagine most of us, because we're not healthcare systems, probably fall more into the small organization piece. Or you may kind of be in the middle somewhere, and so you kind of mix it up. This particular one, the strength of recommendation is medium. So if you think about those three levels, medium, strong, and required, this is sort of, from their standpoint, one of the lower priority practices. But because it's part of this guide, they're all things that I recommend that you have an awareness of. The implementation guidance is, like I said, the examples of what could you do to meet this particular recommended practice. I think I skipped right past implementation status. Like I said, it's a five option. And so you pick where you're at. A lot of times I do the implementation status after we've kind of made the assessment notes, because then we know where we are because we've talked through it and can make that decision. this EHR limitation box is where if there's something that is part of the recommended practice, but your EHR doesn't do it that way, again, that's okay. But, what does the EHR do? What do you all do to kind of overcome whatever that limitation is? If you select an EHR limitation, I highly recommend that you make a note in the assessment notes as to what that limitation is. And so, like I said, if your EHR doesn't do a particular recommendation, but in the alternative, they have this as an option, make a note of what that sort of alternative is. Then, if your implementation status is anything other than fully implemented, this is where you note what the follow-up action is and who is going to be responsible for it. This is part of these follow-up actions, and the person responsible is part of what I put in those assessment team notes at the beginning. So it's kind of that summary of these are the things that we still need to work on. And so each of the practices has a worksheet page for it. Some of them, and I was going to just kind of scroll through these. Every now and again, the implementation guidance is more extensive, and so it goes on to more than one page. And so with AI, for example, which is newer and definitely needs to be part of data governance and discussions and things like that, their implementation guidance actually goes into a second page because they have lots of ideas on things that you could do. So, like I said, as a general rule, the worksheets are one page. In some cases, they do extend further. And so then, and I apologize, I'm going to scroll quickly. Then when you get to the end of the recommendations, there are the references. And so there we go. This is where the evidence-based information that they base the recommended practices on comes from. And so if there's anything that you want to dig into further, this is your, what is it, a bibliography and a report. This is your sources. Like, this is where they pulled that from. This is who published, like, this particular article. It's out on nih.gov. And so that kind of gives you the ability to dig into resources if you choose to. And so I'm actually going to switch. Any questions on that specific guide? That over here for now. Okay, so you can see my slides again, correct, Maria? Thank you. Okay, so my best practice recommendations is, of course, make sure you fill out the team worksheet. And like I said, I use the assessment team notes as kind of a summary of follow-up actions and who is responsible for that so that you kind of have a succinct location for that information. You can also use it to note challenges, things that you know are coming up, those kinds of things. And so, like I said, it's kind of your key takeaways. And as I kind of mentioned before, the rationale for practice or risk assessment and that implementation guidance can provide a lot of insight on the recommended practice, because the rationale is essentially the why. They pick that as a recommended practice. And then that implementation guidance is the ideas. Some of the ways that you could implement this are, and it has kind of a list. I always recommend that you document all three fields. So the assessment notes, the follow-up actions, and the person responsible, the places that you can type. If you're fully implemented, then you can just indicate like not applicable in follow-up actions and person responsible. I don't know how much you all know about me, but my background started in legal. And so I highly recommend that you fill out all the fields so that it's clear that it wasn't something that you forgot to respond to or that you didn't think about, that you just didn't need to put anything there. Also, make sure that you can pick whatever your implementation status is. If you do check that EHR limitation, make a note. Just, this is what my EHR vendor does. This is, an alternative, what they have for this recommended practice, or this is what we do in combination with what the EHR does to do this recommendation. And then after you've gone through the worksheets and you have selected those implementation statuses and, when applicable, indicated an EHR limitation, you actually do have to go back to the worksheets and make those notes because unfortunately they don't carry over in the new version of the form. Okay, so that was a little bit over 30. But that is the overview. And so any questions on that document, kind of what it involves, anything like that. And then I did notice there were a few folks who joined a little bit later. We are recording this, and so if you want to catch the beginning of the recording, it will be available. Okay, so because this is kind of the end of the first section, I'm going to drop in the evaluation survey. I'm also going to drop in my contact information if you decide to do this and you have questions, then you can certainly reach out to me. How many would like to continue to move forward and go into at least some of the questions on that high priority practices guide and just sort of dig in and look at the various pieces? I don't think I can see raised hands. Or have you, like in this first half of the session, have you mostly gotten what you needed as far as information purposes and you are ready to wrap up for the day? Because either of those options is completely acceptable.
I did want to mention that if you are on eClinicalWorks, eClinicalWorks does have safer guides on their My eClinicalWorks website. You have to have access to that, but they are not updated to the 2025 model. They're still there's a couple addendums from like 2019 and 2020, but they have not been updated yet. So they're similar. I mean, it's still kind of, you can always reach out to your SAM, and they will actually help you do these with what Trisha's gone over. But I just wanted to let everybody know, if you're on eClinicalWorks, you can get on to the My eClinicalWorks site and either download the safer guides for ECW as a PDF, or you can actually have them help you complete them.
Which is nice that they've done that, because I know, like I said, the hospital that I was helping do these, there were several things that were like, really, that's a vendor responsibility. Like they should be doing this, and so for example, there was some stuff around the clinical decision support rules, if, providing feedback and that kind of thing. Well, as a general rule, your EHR vendor is creating your clinical decision support rules. Now, if you notice that something seems to be triggering inappropriately, it would be your responsibility to reach out and say, like, hey, I was seeing a patient and this popped up and I don't understand why, because it doesn't apply to this patient. And so that's where, like, the clinic involvement piece of that is. And so, like I said, there's always, even when it's primarily a vendor responsibility, there is still a clinic aspect to that. Since you all are still on the line at the moment, I'll go ahead and I'll pull the guide back up. And we can just dig into a few questions so that you can kind of see how they may apply to your organization. I'm going to scroll real fast. So like on this question, this is a culture of safety type question. And so it's saying your highest level decision makers in the organization, such as your board of directors, owners of practices, C-suite executives, clinical leaderships, commit to promoting a culture of safety that incorporates the safety and safe use of EHRs. And so in this case, like, the rationale for that is essentially that top executives encouraging that focus on safety, providing feedback if you have concerns, helps organizations actually engage well with this, more so than if, say, your top executives aren't prioritizing those kinds of things, either by not providing the human resources or not providing the financial resources. Um, and honestly, sometimes we're all doing the best that we can with the resources we have, and they have enough things going on that, you know, you pick what you prioritize, and the first thing is serving patients. And so you just want to make sure that you're doing that first, and then a lot of stuff, including some things like this, become a secondary thing. Um, One of the sources that they don't necessarily list that you may also engage on some of these questions would be if you have contracted IT support. And so in assessment notes, you would note, what your organization is doing sort of at that executive level. Are they implementing and holding people accountable to policies? For example, are they ensuring that proper training is occurring? Are they making sure that, identified potential EHR related or the EHR related patient safety goals, are they telling you what those are? And so those are the kinds of things that you would look for in this type of a process. Um, and then, like I said, that stuff all goes in assessment notes. And so really your assessment notes should for sure always have something. And then you kind of pick where you are. If, they're not prioritizing safety for whatever reason, then you could note a follow-up action as far as, engage C-suite in addressing EHR safety concerns, um, and then assign somebody to perform that task. And so it some of it is going to look familiar as far as the approach because it is somewhat similar to a security risk assessment. Because, assessment notes are essentially your compensating controls. What are you already doing? What is your EHR already doing? And then follow-up actions come into place when there's something that could still be done. Um, the second practice is that users are warned when they attempt to create a record for a new patient whose first and last names are the same as another patient, or when a patient search returns multiple patients with the same name or similar names. So part of this is going to be an EHR functionality. The EHR, if it sees that you already have Jane Smith in your record, should say, hey, wait a second, and ideally a first name, last name, and maybe date of birth, because a lot of times that date of birth is what can help determine, is this really the same person or is this a junior and a senior, for example? So having something in your EHR that says, hey, we think this person is already there. Are you sure you want to do this? If your EHR doesn't do that, then you can check that EHR limitation and indicate that the EHR does not warn me if I am creating a potentially duplicate account. This is where those eClinicalWorks guides can be helpful, keeping in mind that the numbering, because if they're running off the 2016 version, the numbering is different. I actually tried to do some matching up of the various pieces, and unfortunately, there's not always clean matches. As a matter of fact, there are very few clean matches from the previous version to the new one. But this is something that you could check with your vendor too, of, do you have plans to put this kind of a control in place? And so then as an organization, like if the EHR doesn't warn you, perhaps your policy would be that, you put in first name, last name, and date of birth, or I know you can even search by date of birth. So if you search by date of birth, does that patient already come up? Because if yes, probably already in the system, go ahead and use that record. If you put in the date of birth and that patient does not appear, chances are not in the system. And so that's where, like I said, you would note what your policy is and what your EHR's capabilities are. And then if you don't consider this fully implemented, then you note the follow-up actions and the person responsible. And by the way, if you all have any questions on any of the specific recommended practices, feel free to unmute and interrupt or go ahead and note something in chat, and we will address whatever questions pop up. The third recommendation is that patient data and software application configuration settings critical to the organization's operation are regularly backed up and tested. So again, there's some overlap with HIPAA here. Because it's making sure, and also keep in mind, this is your configuration settings. And so if your EHR is hosted, this is going to be largely your vendor's responsibility. And so, is there a mirrored copy somewhere? Or is there a backup that you can download nightly, kind of a thing? Because that would tell you sort of what your options are from a software standpoint. And so, especially for hosted, vendors should be handling this. If it's a local server, make sure that your EHR, when it is backed up, is not just the data, but is also the configuration. See what your options for that are. Or if there's a way to kind of save like if you're doing updates, save a rollback version. So if something doesn't go right in the update, you can roll it back. And it's not, and I notice in this one, the implementation guidance says a complete encrypted backup of patient data. So they are also considering this to be the patient data, even though they specified the configurations in the recommendation. And so it's wanting to make sure that if you needed to, you could bring the system and the patient data back up. So like I said, this is probably something you've been addressing with HIPAA anyway. But this, like the goal is to make sure that should something happen to your EHR, that you can get it back up and running with minimal data and minimal time loss. The fourth recommendation in that first section is the EHR-based secure messaging systems ensure accurate, reliable, and efficient transmission of high-risk information. And so this is a big focus of this is making sure that any critical or time-sensitive messages are clearly differentiated. So if you send an urgent request to your providers, is there an exclamation mark? Does it turn red? Does it pop to the top of their inbox? Like, again, some of this is going to be highly dependent on your vendor. And so if you feel like there's not a clear indication, then you could certainly indicate EHR limitation and then explain why you feel like the EHR isn't doing this. But then the other piece of that is what are you as an organization doing to kind of fill the gap if necessary? And so, if there is something, maybe it turns that message bold, but it's still black text. There's no exclamation mark or anything like that. Maybe that becomes a training thing then, that if that message is in bold or italics or something specific, these are urgent messages. So, kind of focus your attention there before you go back to the more routine types of messages that you're getting. The implementation guidance, like I said, can be really useful because it talks about things that you could do. And so one of the things that notes is like a follow-up. So if you know that if a provider got part of lab results, but there's also some pathology, so they want to kind of follow up in 5 days to make sure they got the pathology results, can they do something like that? And so, like, kind of taking a peek again at these implementation guidance pieces gives you an idea of ways that you could go about meeting this particular recommended practice. And then artificial intelligence. And like I said, anything related to artificial intelligence within these guides is new because obviously AI was not nearly as big a deal in 2016. But this one is, making sure that AI-enabled application developers, EHR vendors, and healthcare organizations are using AI-enabled systems, hold on, or EHRs with enhanced AI features or functionalities, and that they share responsibility based on their ability and resources available for ensuring AI safety. The shared responsibility includes appropriate clinical, technical, and administrative governance, policies, procedures, people, and technology to ensure AI is monitored and that its use is safe, secure, private, ethical, and equitable. That's a lot of words for a recommendation that says making sure, in essentially, the AI is working correctly and it's not compromising PHI. And so there is definitely a governance piece that needs to go with this one. Um, what are your policies are? What are your policies around implementing AI technology? Like who assesses the AI, what it does, monitors the results, make sure that the patient data is encrypted and protected. It's all about those kinds of processes. And so, like I said, AI is becoming more and more of an opportunity. And so I know like one of the big AI pieces obviously would be a scribe system. Some of the scribes save recordings for 15 days or 30 days or some period of time that's the entire visit. And so verifying that after 30 days it is indeed purging those recordings. Because hopefully by the time that purge period for a recording for a scribe program has expired, your notes are completed, signed, and hopefully billed. And so that's that's just making sure, like I said, that it's behaving as intended. It's not providing false information. It's not missing pieces. Because one of the things too is certain AI algorithms around population health um, were not always designed to take into account, people of color or gender differentiation or that kind of thing. And so making sure that, for your patient populations that these AI algorithms are seem to be working correctly. Because if they're not, again, as an organization, your responsibility is then to reach out to the vendor, whomever that is, and say, hey, I noticed in these scenarios, I either expected this to trigger or I didn't expect it to trigger, and it is not behaving in the way I anticipated. So then everybody can kind of work on refining those algorithms. And like I said, AI, they have a lot in this one. So they have a lot of recommended or a lot of potential implementation guidance on this. Um, Again, you could be doing one of these, you could be doing more than one of these things. You may be doing something completely different, and that's okay. If what you're doing is making sure that your use of AI is safe and that your data is protected. Okay. Any questions on that first section of questions? Okay. So the second set of questions, the first one in those is that healthcare organizations and EHR vendors share responsibility for identifying and addressing EHR safety concerns. So this is obviously your vendor should be doing some testing. When they make changes, they should be doing internal testing. They should probably be doing some beta testing because I used to work for Garmin as a software developer. I was actually on their, like the computer support side of their team. And heavens knows people can do things with computer programs that we never anticipated them doing. And so beta testing, very important. And so that's your vendor side of things. For your organization, you also need to be monitoring these things. And so if, for example, you are sending a prescription and for whatever reason the dosage stuff is not coming across correctly, or the interface has broken, and it's not actually getting to the pharmacy that you're trying to send it to, then you work with the vendors to be like, hey, I have concerns about how this is working. This is what I'm experiencing. How do we fix it? And so, like I said, there's definitely that combined effort from the vendors and the clinics. Because the other thing is that when it comes to testing, and even when they have beta testers, there may be various patient types or, things, there may be specialty type things that you all are doing, that the EHR vendor like didn't have anybody who beta tested that piece. And so making sure that you do have processes and that either safety concerns are reported to someone at the organization, maybe a super user, or that staff as appropriate can submit it directly to the vendor. And so through like a ticket system or something like that. Um, a lot of ticket systems will allow you to copy someone. And so if there's somebody who, like for your risk management, for example, is kind of keeping an eye on this, copying them onto tickets that are submitted helps them keep an eye on status. Um, in this one, the EHR inbox and its use is optimized to reduce inbox burden. And so this also kind of goes back to that, making sure that clinicians can focus on important and high priority information. Um, and sometimes this is, maybe you keep the clinically focused stuff in your EHR inbox and you keep operations type stuff in maybe Teams or some other sort of, or Slack or whatever messaging program you're using, so that you're not getting, non things that are not pertinent to patient care into the EHR's inbox system. You're using something different to handle those. And so, um, some of the suggestions, for example, are does your EHR allow the users to organize and prioritize? So can they sort or filter or flag? And so the first part is what does your EHR vendor do to help make sure that you can optimize your inbox and grab providers, in most cases, attention with the things that you need them to focus on first. Um, or they can flag things for follow-up later. What is your EHR doing? And then kind of what is your policy as far as how do you handle those? This recommendation is that patient photographs are collected during patient registration and displayed in multiple places in the EHR to improve patient identification. And so, most systems provide a way for you to capture a picture of the patient or to, say, scan their driver's license or other photo ID and use that picture. Um, and the goal behind this particular one, we do take that one for granted. We assume that the EHR has this and that it can be put in there. Now, is a patient refusing to take a picture mean you're out of compliance? No, because a patient can be like, no, thank you. I do not want to do that. I apologize. That home phone almost never rings. Um, and so it's not that you have to have every picture for every patient. But the goal is to make sure that throughout the record while you're working with the patient, that ability to I'm sorry, I'm going to pause for just a second.
Following an email, if you could reply to that with some details on that business, that I can take a look at that and see what options we might have, and we can go from there. Thank you.
Oh, I stopped the share. Sorry, that was not the goal. Hitting the wrong buttons. Reshare. Share. There we go. Sorry, I actually meant to mute that because my phone was louder than I realized. Share on 3. And so, like I said, it's not that you have to capture a picture of every single patient. That is not the requirement. Can you see my screen again, Maria?
Yes.
Okay. And so the important thing is to have a process in place. Like, how do you make sure that the patient you are seeing is the patient that you like, the patient record that you're looking at applies to the patient who is with you. And making sure, if, for example, family members are trying to share insurance for whatever reason, like pictures can help you go, wait a second, you don't look like the Maria on the record. So, we have some more questions for you. And so it's to help make sure that those, it helps with that patient identification. Also, if your EHR allows you to go ahead and have more than one patient's record open, it can also be that visual trigger of, oh, wait a second, I had this other one opened. The patient I'm with, for whatever reason, has now moved to the background. I need to bring that back to the foreground to make sure that I'm documenting in the right spot. And so that's the intent of that particular recommendation. This one is regarding test follow-up. And so it's saying that written policies specifically specify unambiguous responsibility for test result follow-up with a shared understanding of that responsibility among all involved in providing follow-up care. And so part of this is, if it's not your providers following up, because I would assume they're mostly going to be either critical follow-ups or they may be letting, say a nurse or someone know that they need to see the patient. If there's something that is some sort of critical result that they may need to adjust a treatment plan, that kind of thing. So part of it is what's the process for making sure that those test results get shared to the person who's going to do the outreach. And do you contact patients for all test results? Do you contact patients for specific test results, or, are higher critical lab values, for example, are they a phone follow-up versus if everything is within normal limits, then that's a letter follow-up. Having those processes in place to make sure that somebody is following up with patients as needed, so that patient care doesn't end up kind of falling through the cracks because the patient didn't realize their A1C was high, for example, or that, they may need to change something in their blood pressure management plan. Actually, they would know that at the day. Or if they did a mammo, for example, and there was some results that came back on a mammo that they need a follow-up biopsy or something else. So it's making sure that that care is getting taken care of and that patient is being notified. And then the fifth one in this section is that system hardware, operating and network software, and clinical application version updates, modifications, or local customizations are tested individually and in the context of other integrated systems using a standardized approach, which consists of testing before go live and is installed in production to ensure adequate performance and data integrity, testing based on real-world, clinically authentic, and relevant scenarios incorporating collective workflows, monitoring all systems for a short time following any hardware or software changes, and then notifying end users before and reminding them after of potentially impactful changes to applications or clinical content assessments. Some folks have a test environment, essentially. And so, but some folks don't. And so you may only have your production environment. And so if you only have a production environment, your vendor is who you're depending on to do this kind of testing. But that last section, that notifying end users before and then reminding them after, a lot of times vendors will release notes for updates that are coming, and the changes that are going to occur. And so having somebody who, reads through those and goes, oh, this could affect our MAs that are rooming patients. This could affect our population health processes, and kind of identifying what those things might be so that they can let users know, hey, the update is scheduled for this date. It may affect these things. So if you see any issues, if something's not working, let us know. And so, like I said, this is doing what you can to make sure that those transition processes go as smoothly as possible, hopefully have minimal impact on operations, and all of your data stays intact and as it should. And then the sixth part of this one is that CDS alerts and reminders provide unambiguous guidance in the correct clinical context at relevant points in the workflow. Alerts and reminders are informative, actionable, and judiciously limited to the most significant patient-specific notifications. EHR vendors tend to develop a lot of clinical decision support rules. Now, whether all of them apply to you or whether all of them are things that you want to prioritize in the patient population you see, can definitely be different. So chances are you're not activating all of the possible clinical decision alerts. You have someone, ideally a team that's kind of multidisciplinary to go, yes, this would be appropriate, or well, this could just become noise. Because you don't want to, like, the judicious aspect of that is you don't want to have so many pop-ups that they just start ignoring them and clicking OK and moving on and not even reading them. And so those, however that comes up, needs to occur at some relevant point of care. And so if there's some sort of follow-up care or some sort of preventive care that needs to happen, knowing that, say, at the beginning of the visit, or if you're doing huddles, maybe you've looked at this already and you're aware of what those things are, but making sure that your use of those clinical decision support rules is helpful for your staff. And this is another one that has some extra implementation guidance for it. And so, again, useful information for some ideas. But the big thing is, what is it that you are doing? And then this is very pertinent, of course, to our current healthcare environment. Users are trained on ransomware prevention strategies, including how to identify malicious emails and fraudulent telephone callers asking for login access or other privileged information. Our staff should absolutely know that the help desk is not going to call and ask for their password. They don't need it. They can access if needed, they can access their information in other ways. And so if someone calls and says they're the help desk, and they need your password, staff should know, absolutely not. I'll just call my help desk directly. And there's becoming a lot more instances where fraudulent people are calling your help desk and saying, hey, I'm user such and such, and I don't remember my password, or I've locked out my account. Can you help me? So part of that too is training with your support staff of, what do they need to do to make sure that this is the proper person? Are they looking for, say, a call from an internal phone extension or something like that? So having identification processes around that stuff. And so phishing training is a common thing to do. And these folks, they are getting better every day. Like I've had several emails that I noticed that Microsoft, it looked off, and it took me 3 tries to realize that Microsoft had 2 S's. And I was like, oh, that's why it looks off. It's not really Microsoft. So that training, and again, this aligns with HIPAA as far as information security awareness training. You want to make sure that you are doing the very best for your staff to make sure that they're not responding to something that they shouldn't be. And so because people in healthcare tend to be helpful, and so you want to make sure that they sort of filter their desire to be helpful with some caution. And then staff are trained and tested on downtime and recovery procedures. And so if your EHR is unavailable, if it's hosted, this in theory is less likely. If it's local, I would assume that you would have generators in place so that the EHR would still be available as needed. But if the power is out, do they use hotspots instead? Or, if somebody cuts the internet line, is there a rollover line that it goes to? And if, for those types of circumstances that may happen for you, do your staff know what they need to do? And worst case scenario, is there paper forms that they could filter back to? In a clinic environment, if you are at a paper level functionality, you may end up closing the clinic just because there's it's not that you're doing, emergency care. It's not that you're doing that kind of stuff. And so you may just choose to close the clinic rather than moving to a paper process. But whatever your process is, how are staff trained on it? And if, for example, the clinic closes because, you had a snowstorm and your power is out, because Maria loves all the snowstorms. Um, making sure that there's some notification process if you do close the clinic for both patients and staff to say, hey, actually, because of terrible roads today, or um, because we have lost our internet line, we're going to have to cancel patient care. What are your processes for? And do staff periodically practice that, or do you talk to them about it so that they would know what to do in the event that they needed to? Okay. Any questions on section 2?
I would say the one you just went over,
Mhm.
to make it clinically, like if you have any questions about this, clinically aware, this can run parallel to your VFC audits and how you run your VFC. Their contingency is
Ooh,
really
good point.
structured, with immunizations. We love when we have immunization problems. But if you are as strict with everything else as you are with your immunizations, it can run parallel. So you can really only do one instead of having to do two contingency type plans. You can just work off each other.
The vaccines is a really good point because, if your fridge goes out, for example, and which is somewhat of a recovery procedure, um, you can have a lot of money sitting in vaccine fridges. So what do you do? Like, do you have coolers? Do you have a secondary site? And so again, making sure, one, that you have policies and processes in place, and two, making sure that staff are aware of what they are so that they can do what they need to do when the day is not going as planned. Anything else on the section 2 pieces? Okay, section 3 is shorter. Organizations have a strategy and mechanisms for prevention, identification, measurement, monitoring, and mitigation of high priority EHR safety risks and hazards. Part of this, again, is going to be your vendor, because if you have risks or hazards that you're seeing in the EHR, you're going to be, I would assume, reporting those to your vendor. But who on the vendor side is monitoring that? Is there anybody on your clinic side that's looking at those to make sure, that prescriptions not sending properly are, 14 days out and still haven't been addressed by the vendor? And so, like, having those monitoring process to make sure that those tickets are moving in whatever way they can move. Sometimes they keep elevating you to various levels of support. But like I said, making sure that any high priority safety risks or hazards are addressed. Sometimes you end up having to do a workaround. And so part of it is going to be, does the vendor, fix this? And you need to stop using the workaround because they've fixed the issue with the functionality. And so, like I said, that's where it is important to have somebody monitoring those risks and hazards. This could be an incident reporting process too. And so, like you said, it just kind of depends on your policies and your processes and organization, but making sure that you're aware of what those concerns are is important. The second one in this set is the organizational policies and procedures ensure timely patient notification of both normal and abnormal test results, and the timeliness of notification is monitored. And so, like I said, in this case, it may be that patients with normal results get a letter and patients with abnormal results get a phone call. Or, you push normal, a letter or a message on a normal patient result out to, say, the portal. But having those processes to make sure that patients are getting their results. And so, they know if everything is all good, or if there's something that, either needs to be monitored, or maybe there needs to be an adjustment in the treatment plan, or they need some sort of follow-up, making sure that you do have processes in place for those kinds of notifications. The third one is that the EHR enables the monitoring of important communication patterns related to clinical messages, referrals, and patient portal notifications. So, like, a big part of this is, what are your workflows? And so if you're sending clinical messages, if you're sending portal messages, or if you're sending out referrals, what are your follow-up processes? What caused things to flag if it hasn't been addressed in a predetermined period of time? And so, like I said, some of those may be technical controls. So like a follow-up flag could be one of the things. So with a referral, for example, if it typically takes a month for a patient to see that particular specialist, set some sort of a follow-up reminder for, say, 35 days. And if you haven't received follow-up, reach out to the referral provider. But this is making sure that those communication loops can get closed. And that something isn't just sort of hanging out there, not being addressed. Okay. And like I said, these are the references. This is the resources. So anything that you happen to want to dig deeper into, you certainly can. Any questions on that last section of the Higher Priority Practices Guide? Okay, so I'm going to minimize this, which should, okay. So let me post the link for the evaluation back in chat, just in case it's kind of disappeared or somebody joined after I put it in there. Where's my chat? There's my chat. We really appreciate your help with these evaluations because they do help us understand the efficacy of our training, to identify opportunities for improvement, and they enhance our grant reporting. So please go ahead and fill those out for me. I'm also going to put my email address in there again. If you find yourself completing this and you have any questions as you go through, I will certainly help you to the best of my ability. This process is like any risk management process. And so you're documenting what you're doing, what you may need to do, and just kind of taking a snapshot of, this is where we are. We feel like we're good, or this is where we are, but we feel like we need to do whatever the thing is. In the slides, and we will send these out after the session, we'll also send out the recording. I have both the main site for the SAFER guides as a whole, as well as the High Priority Practices SAFER guides specifically. It also has my contact information, both my work and my work phone number, and my work cell phone. Otherwise, last call for questions. Okay. Thank you for hanging in there with me. I appreciate that. I wasn't sure how many folks would want to go through the whole thing.
Thank you.
Yes. Thank you.
Trisha.
Yes, ma'am. Did I hear Cornelia? Oh, okay. Yep. You're welcome. Thank you all very much. We appreciate you sharing your time with us today.
Thank you.
All right. Thank you.
All right. Bye.
Bye-bye.